Good morning, everyone. I was looking at the two empty tables in front of me as I was wondering, am I that scary? But I guess, I guess if they're, I guess primary care people and engineers like to kind of take a back seat, right? So when John asked me to talk here, first thing I thought was, what can I say about primary care and engineering that would make any sense? And I thought about it for quite a while, and I was happening to talk to a young person who just finished their residency in family medicine at San Francisco General, where I work. And he said, I'm trying to figure out what to do with my career. And he's very good. So I said, I think you should be the first ever professor of primary care science. And then I thought, and he said, okay, tell me how to do it. So then I thought, primary care has become a science. So I was in private practice and worked in community health centers for 32 years doing full-time primary care, and primary care was chaos. It certainly was not a science at that point. But since then, things have changed a lot. And so what I want to talk about today is the science of high-performing primary care. I've never done this talk before, so we'll see how it goes. And please feel free to either interrupt, jeer at me, make suggestions, etc. I'm perfectly happy to have people interrupt in the middle. So here we go. So first I had to figure out what science was. So this is one definition: intellectual and practical activity encompassing the systematic study of the structure and behavior of the physical and natural world through observation and experiment. And I thought, I hope the natural world includes human beings, because that's really what we're talking about. I know you all know what primary care is, but just wanted to sort of review the great Barbara Starfield's 4 pillars of primary care. So from a patient's point of view, it's where I go first when I need care, first contact care. I see the same clinician whenever I need care, which is continuity of care. My primary care clinician takes care of most of my medical needs, which is comprehensiveness. And if my primary care clinician can't solve my problem, she coordinates my care with specialists, hospitals, and other services, which is coordination. And I'm sure you've all heard about why primary care is so important and so valuable. There's a lot of research done on this. I want to specifically talk about the second to last bullet point. For Medicare patients, this is states in the United States, the 50 states, states with more primary care physicians, and this particular study was just physicians, but I think we're going to talk more about primary care practitioners, which is physicians, nurse practitioners, and physician assistants. But this particular study was on physicians, so the more primary care physicians per capita have higher quality and lower costs. States with more specialists and fewer primary care physicians have lower quality and higher costs. An amazing study. So one of the things that we've been doing at the Center for Excellence in Primary Care, where I work in the Department of Family Medicine at University of California, San Francisco, we've been visiting a lot of very good primary care practices. So we call them bright spots. And as you know, some places work really well and some places don't work well at all. So there are bright spots and dark corners, and you need the bright spots to illuminate the dark corners. So we learn from the bright spots, and then when we go to places that really need help, we try to take the learnings that we have from the bright spots and try to apply them to the places that are challenged. So this is a list of some of the places that we went, and we coordinated this with Chris Sinsky. And so a number of people between her group and our group went to all these practices. And what was really interesting was, if you look at those practices, some of them are community health centers, some of them are small primary care offices, some are in big integrated delivery systems. So they looked very, very different from the outside. But interestingly, they looked very similar on the inside. So it's like, okay, good primary care sort of looks the same no matter where you go. So these are the practice that some people would call patient-centered medical homes. We call them high-performing primary care because not every practice that calls itself a patient-centered medical home is actually high-performing. So in trying to figure out what those practices had in common, we came up with this concept of the 10 building blocks of high-performing primary care. So one thing that is interesting about this is that there's if you look at like what does primary care need to look like in the future is actually here. I mean, we know that these practices are the way to go. The problem with the future is that it's unevenly distributed. A lot of places haven't seen or haven't made the changes that they need. But to develop the science of primary care, we really want to look at high-performing primary care. That's where you get the science from. So these are the 10 building blocks of high-performing primary care. These are the things that really good practices have implemented. And the 4 building blocks on the bottom are what we call the foundational building blocks. Engaged leadership, you probably are not going to succeed without engaged leadership. Data-driven improvement, empanelment, team-based care kind of is the things that you need in order to get the other building blocks to work. And we're going to talk about some of these building blocks and the science behind them, not all of them. The other thing about the building blocks is some people say, well, the building blocks, that's just your model. And there are a lot of other models. Well, it turns out that the various models, so there's the 10 building blocks. There's learning from effective ambulatory practices. Ed Wagner's study of 30 very good practices around the country. Stanford has a clinical excellence research study looking at excellent practices. The NCQA Patient-Centered Medical Home, the Joint Commission, Safety Net Medical Home Initiative. There are all of these organizations that have looked at high-performing primary care. What does it look like? And they're all very, very similar. I did a whole crosswalk of the characteristics with all of these different people trying to figure out what high-performing primary care was, and they're very, very similar. So we feel like the 10 building blocks is one way to look at it. There are other ways to look at it. They're not much different. So again, that convergence of sort of what good primary care looks like, I think, makes it possible to say that there's actually a science of good primary care. So let's talk about some of these building blocks and what's behind them. So data-driven improvement. So if you go to a really good practice, what you'll see on the wall is you'll see a lot of data. And the data will usually have a particular metric that someone wants to improve, and they'll have what is the target that they're looking for, and have you reached the target or not. And usually if you haven't reached the target, you get a red dot, and if you've reached the target, you get a green dot, and you're trying to get the red out. So bright spot practices really collect, report, and discuss data. So it's not just that you have the data, it's how you use the data for improvement. The data tends to be clinical data, operational data, patient and staff experience data, and financial data. And it really has to be drilled down to the clinician and team level, because really the only way to learn is to figure out the people who are really doing things well and learn from them. Now, the science of data, this is really the facts that we have that show how we're doing for our patients, and we need to figure out how to improve it. But there's also a culture, so it's not all science, there's an art to it or a culture to it, which is that people can use data to punish people, or people can use data for learning. And the really good practices use the data for learning, which is why we call this building block not just data, but data-driven improvement. So the friendly competition between sites and between teams and between clinicians is a healthy competition. As this little cartoon says, our job will be to drag the competition down to our level. So data-driven improvement, a very key part that sort of bolsters the science of good primary care. So empanelment, you really cannot have a good primary care practice if you don't empanel your patients. So when I was in private practice, we had no empanelment. patients didn't really know who their clinician was. Clinicians didn't know, like, you couldn't get a list of all your patients and the data about them. None of that stuff existed back like 25, 30 years ago. So empanelment basically is a very simple concept, which is linking patients to a primary care clinician or team, but there's much more complexity to it. As we know, you need that whole long-term relationship of trust, and empanelment is sort of the basis for that trust to develop. But it's also really important for the data-driven improvement part. You really can't do data-driven improvement unless you have empanelment. Because if you don't know, if you don't know who are the patients of a particular clinician, and you don't have a denominator for preparing getting the quality metrics for that clinician. The other thing it does is allows you to calculate panel size, and panel size is very important for access and for many other things. So the whole denominator, the need to have a denominator for your quality metrics is really what empanelment does. So if you take the great Dr. Beasley, and you're measuring the percent of Dr. Beasley's patients over 50 years who are up to date on colorectal cancer screening. So the quality metric is the number of Dr. Beasley's over 50 patients up to date on colorectal cancer screening divided by all of Dr. Beasley's over 50 patients. So you need to know who his patients are in order to get that denominator. So without empanelment, you can't measure how good or bad a physician Dr. Beasley is. Sorry about that, Don. And when I remember being in practice and someone said, "Hey, Tom, are you a good doctor taking care of diabetes?" I think it was a patient with diabetes who wanted to ask me whether they should have me as their physician. I said, "Yeah, I'm a great doctor with diabetes." And they said, and this was a pretty educated patient. They said, "How do you know you're a good doctor about diabetes?" And I thought to myself, well, I really don't know, because so the person said, "How many patients do you have with diabetes?" And we didn't have empanelment then. I said, "I don't know how many patients I have with diabetes." He said, "What percentage of your patients with diabetes have hemoglobin A1Cs 7 or below?" I said, "I have no idea." So without that data, without knowing how many patients I have with diabetes, which empanelment would allow me to do, I really didn't know if I was a good doctor with diabetes. And actually, I still don't know if I was a good doctor about taking care of diabetes. I hope I was. Now, risk-adjusting panels is another sort of key part of the science of primary care, because as we all know, if you have a young, healthy person, they will have many fewer visits than someone who's 85 years of age and has 3 or 4 different diagnoses. So there are really good formulas available to risk-adjust panels, and good primary care practices do that. So panel size has been a very important, again, we never used to measure panel size because people weren't empaneled, so you didn't know how many patients you were responsible for. We actually don't know very well what the average panel size in the United States is. It's never been really well measured. It's estimated that it might be 2,300 patients, but no one's totally sure. But the family medicine department at Duke did this sort of mathematical exercise to figure out, like, okay, if you have a panel of 2,500 patients, how long would it take you to do all the recommended primary care tasks that need to be done if you don't have a team? And they figured out that it would take 7.4 hours every day for one practitioner to do perfect preventive care for a panel that size, which is a lot of time. But if you add really good chronic care for a panel that size, that would take 10.6 hours more. So that's 18 hours a day to take care of a panel that size, doing really good care for chronic care and preventive care. No time for acute care, no time for care coordination, or no time for having a life. So what they essentially showed with this mathematical exercise was a panel of 2,500 patients is too big for a primary care clinician to take care of by themselves. Either you have to have fewer panel size, or you have to have a team. There's no other possibility. Now, team-based care is an area where we really, the science is not very well developed. And I understand that you had some talk yesterday about team-based care. Maybe the science is more developed today than it was before yesterday. But in general, the research on team-based care is kind of sparse in terms of what really is the difference between a good team and a bad team. So we've, in all of our primary care practices that we went to that were high performing, we looked to see, like, what are the characteristics of the teams in these practices? And we've found that there are probably 9 elements of high performing teams: a stable team structure, co-location, a culture shift of sharing the care, defined roles, standing orders, defined workflows, staffing ratios, ground rules, and communication. That's a lot of stuff. When Amira and I worked on this team building guide, we searched the literature for all of these elements of high performing teams, and we didn't find that much. It was surprising how there's not a lot of sort of research support for these different elements. These are things that we observed in the high performing practices, but there's not a lot of research to back it up. Now, co-location is one area where actually there are a couple of articles, and Dr. Munt, you here today? Yeah. Hi. So I thought your paper was really interesting in terms of the density of interactions among people on the team. And I figured, if the team is co-located together in one space, they'll probably have more dense interactions. So maybe this is some science that backs up co-location. But if you go to a practice in which the team is co-located together in one space, like this team is, so here you have a clinician and the medical assistant that they're working with sitting next to each other. They talk all the time. It's really wonderful to look at a team that's co-located in this way, rather than having all the nursing staff or medical assistants over in one area and all the physicians or clinicians in another area, and they have a hard time sort of communicating with each other. So co-location really works beautifully. There was finally one very, very good study done, which came out in JAMA just last year from Intermountain Health in Utah. And they have many, many primary care practices, and they've been working on team-based care for probably 10 or 15 years. So they compared teams in 27 practices that were very well-developed teams that had been working as teams for at least 6 years and had certain characteristics. And they compared that with 75 no-team practices. And there are a lot of patient years in this study. And what they found is that the patients in the team-based practices had significantly more depression screening and high performance on diabetes care bundle, plus lower rates of utilization, lower rates of ED visits, lower hospital admissions, and lower total cost of care. So this is one of the few, maybe the only, study that really looks at teams and like, what is the effect of teams on patient outcomes and costs of care? So we need more work like this. But this is a landmark study. Okay, let's move on to population management. So again, back to my old practice. Basically, the way I practiced medicine was I worried about the patient who was in front of me at that moment or who was going to be coming in today. I didn't really think about anyone else. So with population management, you're worried about the whole population of patients you're responsible for. So if you're a practice, it may be a big population. If you're a clinician, it may be the people who are empaneled to you that you're responsible for. It's a very different way of thinking. So I think good primary care always does not only individual clinical work, but also thinks about the population of patients they're responsible for. And really the basic science behind population management, I would say, is the chronic care model. And when you develop science, you always have certain people who are sort of the champions of developing that science. And certainly Ed Wagner is one of the great champions of primary care science who developed the chronic care model. And when he started writing, he thought that really the typical visit was a acute care visit. And it's very interesting that if you look at the number of agenda items that get taken care of in the average 15 or 20-minute primary care visit, it's 7.1, which is ridiculous. That's like 3 minutes per problem. And what Ed pointed out was that if you have all of these things that a patient wants to talk about or that you want to talk about, the acute problems always have to come first because they're acute. They're more urgent. So the urgent issues crowd out chronic care and preventive care. So there's really often no time for chronic care and preventive care. So you really have to separate out in a way and have planned visits for chronic care so that you can separate the acute from the chronic, because it's correct that the acute should crowd out the chronic care, but then you have to figure out how you're going to do the chronic care. So this is the tyranny of the urgent, which sort of started Ed going on a whole way to figure out, like, what is good chronic care? How is it done? And he came up with the chronic care model, which is pretty complicated. There's 6 different components to it. And the 4 components within the primary care practice are the self-management support, delivery system design, a lot of which is planned visits with like nurse care managers to really concentrate on and have some time for the chronic disease, decision support, and clinical information systems, which is back to the data-driven improvement. So if you have the data, if you have empanelment, you can create registries of patients that are in your panel and all the different sort of chronic care metrics associated with it, so you can really identify who has care gaps, who's overdue for different things, which in the list of your list of patients are out of control for diabetes or hypertension or hyperlipidemia, and you can do something about it. So the chronic care model is complicated, but what Ed Wagner did was not just create the chronic care model, but then he spent the next 10 years going around the world to try to help people implement the chronic care model in primary care. And there's quite a bit of evidence that shows that the chronic care model actually makes changes. There have been studies for heart failure, asthma, diabetes, and people who've implemented elements of the chronic care model, their patients have better outcomes. And it's interesting that the more of these 6 chronic care model components that are implemented, the better the outcomes. And we looked at, is there any one of these chronic care model components that seems like it's more important than the other parts? And probably there's not. But it's interesting that if you looked at a whole bunch of different chronic care improvement interventions, self-management support came out to be the most important of all of the chronic care model elements. And self-management support is also known as health coaching. So I want to talk for a couple of minutes about health coaching, because there's now become a science of health coaching or self-management support, which is a key part of the chronic care model. There's also a great scientist who was the leader of developing health coaching, and that's Kate Lorig at Stanford. So health coaching really is, when I went to medical school, what I learned was that we use evidence-based medicine to take care of patients. And we tell patients what to do based on the evidence, and if they don't do it, we call them non-compliant. That was what I learned, and that's what, sadly, a lot of physicians learn in medical school. So the health coaching model is engaging patients to set their own goals, see what they're willing and able to do, and kind of meet them halfway. And we define health coaching as assisting patients to gain the knowledge, the skills, and the confidence to become informed, active participants in managing their chronic conditions. And as Kate Lorig said, if you're confident you can do something, you probably can do it. And if you're not confident, you probably can't. And there's a whole science again of what's called self-efficacy, which is basically people's confidence and ability to do things, and how important that is in allowing people to actually succeed. So this paradigm shift of going from telling the people what to do and then calling them non-compliant if they don't do it toward health coaching has a bunch of components which also have evidence behind them. I just want to list a little bit of this evidence because I think a lot of people feel like health coaching is kind of a fuzzy studies and is not scientifically based, but actually it is. So if you use motivational interviewing, which is also becoming a science, if you use that to engage people and ask them what they need and what they're interested in doing, what they're willing to do, and what they know and what they want to know, that's much better than telling them what to do. It works better. We also know that if people with diabetes know what their A1C is and what their goal is, that they have better control than people who don't know what their A1C and what their goal is. So we teach people in our health coaching what their A1C, what their goal is, what their blood pressure is, what their goal is, and so forth. We also know that 50% of people leave the medical office visit without understanding what they're supposed to do, and that if you ask people to say back what their instructions are, they do a lot better. So that's part of our health coaching model, which we call close the loop or teach back, asking people to say back what the instructions are to make sure they know what their clinician is suggesting that they do. Medication adherence coaching is effective for that. And then we use action plans to help people with behavior change. And that's really an agreement between anybody, could be a clinician, could be a nurse, could be a social worker, could be a pharmacist. Anyone on the team can make these agreements with patients to specify behavior changes that the patients want to make and feel like they're able to make. And there's also a randomized controlled trial that shows that patients with diabetes who had these action plan discussions did much better than if you went to a health educator and just got a lecture on diabetes. And then we did 2 randomized controlled trials in the Center for Excellence in Primary Care on health coaching. One was medical assistants as health coaches were able to improve hemoglobin A1Cs and cholesterols compared with a control group that didn't have a health coach. And we also trained patients to be health coaches, and their patients did better than people without health coaches. So health coaching has really become a science as part of the population management and chronic care model, part of primary care. So again, all of these building blocks have a complexity of science behind them. When you add it up all together, I think one can really say that primary care is a science. Now, when you get to the high-cost, high-needs patients, which we're all so concerned about because of their costs and complexity, we know that the top 1%, or the top 50%, the top 1% in terms of costs incurs more than 20% of total healthcare costs, and the top 5% incurs about half of healthcare costs in this country. So we really need to do something about that. And here's an area, I think, where the science needs much more development. There's a number of studies that have been done, but most of them are not very rigorous. And we've cataloged and written about all of these studies, but I don't think that we're quite there yet in terms of how do you really take care of these high-cost, high-needs patients. Jeff Brenner in Camden, New Jersey, is doing a randomized controlled trial with high-cost, high-needs patients, and it'll be very interesting to see what they come up with and whether that will move the science forward. Continuity of care. So continuity of care, of course, means that patients are empaneled to a clinician, and they always see that clinician when they receive care. And there's a lot of studies that show that continuity of care creates better preventive care, better chronic care, better patient and clinician satisfaction, and lower healthcare costs. And continuity of care is very much of a struggle in primary care because we're much more into part-time clinicians than we were in the past. A lot of practices that are good practices measure continuity of care, and practices that are not so good often don't measure it, so they really don't know how they're doing. And you use this very simple metric, which is the percent of patient visits to the patient's empaneled primary care practitioner over the total number of patient visits. So if you have a panel of 1,000 patients, they make 3,000 visits a year. 2,000 of those visits are with the patient's primary care clinician, so continuity is 67%. And you can also look at it from the clinician perspective. If I see 20 patients today, how many of those patients were patients impaneled to me versus how many of them were patients impaneled to someone else? So again, the example, a nurse practitioner has 300 patient visits in a month. 150 of those are visits with patients of her panel. 150 are patients of another clinician, so her continuity from her perspective is 50%. So those are two different ways of looking at continuity, and you really have to look at both of those to really see how you're doing with continuity of care. And the science of improving continuity is also something that needs a lot of work, because now we're in the era of part-time clinicians. So when my uncle was a general practitioner, and he worked for 40 years, and he was on call 24/7, 365. He was on call for 40 years. So continuity of care was easy, but that's not happening anymore. I don't know how he did it. So you could have two half-time clinicians sharing a panel, and one of them or the other one is always there, so that the patient can, they can at least have continuity with two people rather than one. And we're working a lot with continuity of care in teaching practices, which is really a problem because the part-time syndrome is really well developed in teaching practices, unfortunately. So you have residents there and faculty there often like half a day or two half-a-days a week, so continuity of care is really poor. But if you have a full-time nurse practitioner or physician assistant continuity anchor on each team, and if the front desk is really trained to say, the patient says, I want to see Dr. Beasley. Well, Dr. Beasley will be in next week. Well, I can't wait till next week. Okay, well, how about seeing the physician assistant on Dr. Beasley's team? So they basically have continuity of care with two people rather than one, which is a lot better than no continuity at all or continuity with 8 or 10 people. So again, continuity of care, we know what the metric should be. We know that people should be measuring that metric. But then there's a lot of work to be done, how to improve continuity of care in the part-time syndrome that we live in. Access is another area where there's been a lot of work done. And again, we have a scientist who really developed this work, who is Mark Murray, who's a family practitioner in Sacramento, California. He pioneered the whole concept of open access, which is to have a lot of appointment slots open at the beginning of a day so that people could come in for same-day appointments. And he had this very simple notion that I think a lot of people don't think about, which is if you see 25 patients a day and the patients waited 4 weeks to see you, why couldn't you see 25 patients a day and have most of them have made the appointment the same day or the day before? You're not seeing any fewer or more patients. So it can be done. And he created the whole concept that if your demand and capacity are equal, you can have good access to care. But if your demand is way greater than your capacity, then it's going to be really difficult for you to develop same day or next day access. So he created this formula, which is sort of, if you want demand to be equal capacity, demand is really the panel size, number of patients this is for one practitioner, your panel size times the number of visits per patient per year. That's the demand, and the supply, or the capacity, is the number of patients seen each day times the number of days worked per year. So for example, if you have 2,000 patients in your panel, and on the average they come 3 times a year, your demand is 6,000 patient visits a year. And again, this is more simplistic because this is only individual face-to-face visits. It's not like patient portals or telephone visits or group visits or anything like that. And your capacity is the number of patient slots you have in a year. So it's the number of days you work in the year times the number of patients you see each day. And there are a bunch of measures to figure out how people are doing with access. So one is like the percent of appointments that are same-day appointments. So if you look at the schedule and you say, okay, when did the patient make this appointment? So if all the patients made their appointments 6 weeks ago, then your access was probably really bad. But if you have several patients who made their appointments today or yesterday, so in this case, 50% of the patients made their appointments either today or yesterday, so you probably have pretty good access. Another way to look at it is what we call future open capacity. So if you look at, say, 4 weeks from now, 45 of your appointment slots are filled out of the 50 appointment slots that there are. 3 weeks from now, 25 of the 50 are filled, and next week, 10 of the 50 are open. So there your access is, not too bad. So looking at the future open capacity, if you add up the top line, it's 82, and the bottom line, which is the number of total appointments available, is 200. Your future open capacity is 41%, which is not so bad. If you have really bad access, then there'll be no open appointment slots during these 4 weeks, and your future open capacity will be 0, and then your access is going to be really lousy. Then the final one, which tends to be used the most, is third next available appointment. And what Mark Murray figured out was that you can't look at the next open appointment to figure out what your access is, because someone might have canceled yesterday, but your whole book might be completely filled except for that one appointment. So if you look at the third one, it's most likely to be actually shows how many appointment slots are really open. So can someone tell me what third next available appointment is for this appointment book? How many people think it's 2 days? How many people think it's 3 days? How many people don't know? So if your third next available appointment if all of these were X'd out, all of these appointment slots were filled, say for a month going, then your third next available appointment would be 30 days, which would be pretty lousy access. Okay, so this one, how many think the third next available appointment is 1 day, because there's an open slot? How many people think the third next available appointment is 4 days? All right, it's 4 days. How many people think third next available appointment is 7 days? That's right, it's the third next. So it's a measure of really how many open slots there are, so that people could get an appointment in 7 days rather than in 60 days or 90 days. So we use all of these metrics to try to improve our access. So again, access has become more of a science, and Mark has really worked a lot on queuing theory and how it relates to access and so forth. So access has really become a scientific principle, which doesn't mean that it's easy to create good access. So let's look at these demand capacity gaps a little bit, because there's becoming a whole science about this, and this gets into team-based care. So again, we talked about demand and capacity. So demand is the number of people on your panel times the number of times they come a year. Capacity is the number of slots you have in a year. So in this situation, your demand is 6,000 visits a year. Your capacity is 4,000 visits a year. So your gap is 2,000. So how do we close that gap? Well, it's easy. Reduce panel size? Well, that's not possible because there are not enough primary care practitioners in the country to reduce panel size. So we need to increase capacity. So let's say that so one thing you could do to increase capacity is have practitioners work more days a year. So rather than working 200 days a year, they work 250 days a year. and then your demand capacity gap goes down to 1,000 from 2,000. That's still a pretty big gap, so I think we have to have people see more patients per day. So from 20 to 24, then we have a capacity of 6,000, and your demand is 6,000, so we've solved the problem. Chris, do you think we've solved the problem? Exactly. So physician burnout, as you all know, is a big issue. And so if you push clinicians that far, your demand capacity gap is going to be zero because everyone would have quit. So you have to figure out a different way to do it. And that's where we get back to team-based care. So let's keep doing a little bit more math here. Let's assume you have a panel of 2,000 creating 6,000 visits a year. And let's say this is just for purposes of kind of discussion, that 1,000 of those visits are patients with diabetes, 1,000 are patients with hypertension, and 1,000 are visits with uncomplicated low back, knee, or shoulder pain. Just for assumption. And let's assume we have RNs, pharmacists, and physical therapists in our practice, and that they can independently, without the need for any practitioner, care for 2/3 of those patients. And this is not actually unrealistic. So the total visits by these, what we call non-practitioner professionals, is 2,000 visits. So that's the 3,000 visits up there, and they can do 2/3 of them. So that means that each practitioner continues to do 4,000 visits rather than 6,000 visits a year, and the non-practitioner professionals do 2,000 visits. So we've closed our demand capacity, and burnout either drops or at least doesn't go up because the practitioners are not doing more work. Other people on the team are adding capacity. Now, there's a lot of research that shows that I don't have time to show here that RNs actually can care with most patients with diabetes without the clinician involvement. Same thing with pharmacists, that physical therapists can actually take care of people with uncomplicated musculoskeletal issues just as well as physicians. And people could go to the physical therapist first, and then if there's a red flag, then the physical therapist could refer them back to the clinician rather than the other way around. It works very, very well. And the behaviorist can take care of many people with a mild to moderate depression without a lot of clinician involvement also. So your non-practitioner professionals can actually do a lot of these visits and add a lot of capacity. Okay, just a couple of words about care coordination. So care coordination in our healthcare system is pretty crazy. So you have the PCP who's coordinating care with a pharmacist and with specialists and with labs and so forth, and they're coordinating with each other, and everyone's coordinating with everybody. And it's difficult. So is there a science being developed about how to solve this problem of care coordination in a very fragmented healthcare system, which got way more fragmented with the hospitalist change, in which most primary care practitioners don't take care of their patients in the hospital anymore the way we used to. So Ed Wagner, again, the founder of the chronic care model, has created a care coordination model. This has not been as well accepted as the chronic care model, but he really looked at like, how do we really coordinate care well in this healthcare system that's so fragmented? And one is like, who's accountable for coordinating care? And the answer is primary care is accountable for coordinating care. Someone has to be the person who makes sure it happens. Then you need patient support. Patients may need translators. Patients may need transportation. Patients may need help making appointments. Then you have to have relationships with specialists and labs and so forth to make sure that the insurances are covered, and to make sure that if I send you, the specialist, the patient, you will get back to me a report within the next 48 hours about what you found. So having actual contractual relationships with your partners really makes care coordination work much better. And then connectivity, so like the e-consult that we developed at San Francisco General Hospital, in which you can electronically do consultations between primary care and specialty, is another part of it. So there is a whole science developing for care coordination. It's not been implemented as much as some of the other parts of the 10 building blocks. So, finishing up. There have been a lot of empirical observational studies of high-performing practices, so 10 building blocks is one example. There's some randomized controlled trials, especially in health coaching, chronic care model studies, and continuity of care studies, showing that these things really are important. There are evaluations of primary care practice improvement interventions, which so these don't reach the level of a randomized controlled trial, but you could extract a lot of information from these evaluations. So these are different kind of ways of trying to develop the science of high-performing primary care. So, and really the fundamental part of the science of primary care is excellent data and using that data to improve. So great primary care is a beautiful and a scientific thing. Thank you.